Hello everyone, my name is Matthew Davis and I'm an infectious disease pharmacist at UCLA Ronald Reagan Medical Center, and in this presentation I will be reviewing the pertinent drug information on Remdesivir for SARS-CoV-2, which is the virus that causes COVID-19. Mechanistically, Remdesivir interferes with viral RNA-dependent RNA polymerase, leading to premature termination of the viral RNA transcript. Phase 3 clinical trials are ongoing for its use in the treatment of COVID-19. It is formulated as intravenous use only, and for dosing in adults, there's a 200 milligram load on day 1, followed by 100 milligrams daily thereafter for a duration of 5 to 10 days depending on the trial. The dosing used for pediatrics and compassionate use is 5 mg per kg load with a max of 200 milligrams on day 1, followed by 2.5 mg per kg daily thereafter with a max of 100 milligrams. Examining the molecular structure of Remdesivir, it is a monophosphoramidate 1-cyano-C-adenosine nucleoside analog, and I'd like to highlight a few key points about the structure-activity relationship. First, let's take a look at the monophosphoramidate group. So here are 3 examples of a C-adenosine analog with various 5' carbon substitutions circled for you. On the left, we have the hydroxylated form, which, in order to be activated, requires phosphorylation by intracellular kinases. And there are issues with competition with the endogenous nucleoside pools. Unfortunately, these adenosine analogs must compete with endogenous nucleosides, and this is a rate-limiting step for activity. In the middle, we see the monophosphate form, which circumvents the need for this initial phosphorylation, but this phosphate group is negatively charged, which impacts its ability to traverse cellular membranes. The phosphoramidate moiety on Remdesivir mitigates both of these concerns. First, the substitution is neutrally charged, so there's no impact on membrane permeability. Additionally, once intracellular, the molecule is cleaved by esterases and converted to the monophosphate form, which circumvents the rate-limiting initial phosphorylation. Next, I'd like to focus on the 1' cyano group. So when the parent C-adenosine molecule was tested in vitro without any modifications, it demonstrated very poor selectivity and was highly cytotoxic for the cell lines tested. But when the 1' position was modified to incorporate a cyano group, it conferred high selectivity for viral RNA polymerase's active site, and this led to significant improvements in the selectivity index values. For Remdesivir pharmacokinetics, it is 12.1% unbound to plasma proteins and distributed widely throughout the body. For metabolism, the phosphoramidate prodrug is cleaved by esterases and carboxypeptidases intracellularly. It is eliminated partially through both renal and biliary excretion. And then, although there are no recommended dose adjustments for renal or hepatic dysfunction, the current trials all have exclusion criteria based on eGFR or creatinine clearance cutoffs. A few key points on Remdesivir pharmacokinetic parameters. The prodrug, that is the phosphoramidate compound, is rapidly converted to the nucleoside metabolite, which peaks at around 3 to 4 hours in the body. This metabolite has a relatively long half-life of about 20 to 24 hours, which supports the use of once-daily dosing. For safety information, Remdesivir has been relatively well tolerated in multiple dose phase 1 clinical trials. The most notable adverse event reported is transaminitis, with an onset ranging from 5 to 25 days and resolution occurring 3 to 47 days thereafter. This has led to the development of transaminase-based exclusion criteria for ongoing clinical trials. Notably, a single patient with Ebola in the clinical trial experienced hypertension and cardiac arrest after the initiation of Remdesivir. This could not be distinguished from progression to fulminant disease. Remdesivir does include cyclodextrin solubilizing agent with either 9 grams or 4.5 grams per 150 milligram of Remdesivir, and this depends on the formulation that you receive. To compare, a 400 milligram dose of voriconazole would contain 6.4 grams of cyclodextrin. However, the clinical significance of cyclodextrin in humans is still up for debate. An important note, Gilead has recently clarified that Remdesivir does not meet NIOSH or ASHP criteria for hazardous compound. This will be updated in their pharmacy manuals. Now, Remdesivir has been tested and shown to have submicromolar in vitro activity towards a number of RNA viral families. I'm going to be focusing on further investigation of its use in the treatment of Ebola, MERS, SARS-CoV-1, and also SARS-CoV-2. First, since the majority of us are not virology experts, and this past month is probably the first time we've ever encountered some of these terms, I'd like to define them briefly. So the EC50, or effective concentration 50, which in this case is the concentration required to produce half maximal inhibition of virus yield and viral replication, is the parameter for potency. The CC50, or cytotoxic concentration 50, is a concentration required to produce 50% cytotoxic activity in the cell lines under study, and this correlates to toxicity. The selectivity index is a ratio of the two concentrations, with CC50 being divided by EC50, with a higher ratio, in this case for remdesivir, represents higher selectivity for viral RNA polymerases. Looking at the in vitro activity of remdesivir, it does have sub-micromolar activity for SARS-CoV-1, SARS-CoV-2, MERS, and Ebola, with relatively high CC50s in each case. This translates to high in vitro potency against these viruses and maintaining high selectivity for viral targets. This is compared to other agents being explored for SARS-CoV-2, like the nucleoside analogs ribavirin, penciclovir, and favipiravir, which all have relatively high EC50s. I've also included hydroxychloroquine and chloroquine family, which, like remdesivir, demonstrate high in vitro potency. So why do the other nucleoside analogs have seemingly poor in vitro potency? Well, during the RNA transcription for coronaviruses, there's a proofreading process that is facilitated by an exoribonuclease enzyme. For nucleoside analogs, this translates to being removed from the RNA transcript, leading to decreased activity. However, it appears that remdesivir is able to circumvent this mechanism of resistance, potentially through either evading the exonuclease activity or through conferring a high fitness cost in mutant strains. So let's take a look at animal data. For SARS-CoV-1 in a murine model, prophylactic remdesivir achieved significant reductions in viral loads, prevented decline in pulmonary function, reduced pathologic changes including intraalveolar edema from diffuse alveolar damage, and also improved survival compared to vehicle-treated controls. Similarly, in a MERS murine model, and also in rhesus macaques, prophylactic remdesivir conferred significant reduction in viral titers, improvement in clinical scores, reduction in observed lung pathology, and significantly improved survival in the murine model. The macaques were euthanized at a pre-specified endpoint, so survival effects could not be determined. For treatment of SARS-CoV-1, remdesivir showed reduction in viral titers, improved clinical and pathologic criteria, but survival benefit was only observed with initiation on day 1 of illness and not on day 2, and this highlights the potential importance of early initiation of therapy. In MERS, virologic, clinical, and pathologic benefit was observed in treatment in both murine and macaque models, but survival benefit was not demonstrated in the murine model. For Ebola in a macaque model as well, improvement in virologic, clinical, and pathologic endpoints was observed, but survival effects could not be evaluated. Here's a notable quote from DeWitt and colleagues. "A drug that inhibits viral replication may be of little use once viral replication has reached its peak." So we don't have comprehensive understanding of the viral kinetics of SARS-CoV-2 quite yet, but here's a depiction of the upper airway samples from a cohort of 17 patients and their PCR cycle threshold counts from onset of symptoms. There's currently one published randomized clinical trial that has included remdesivir therapy in the treatment of Ebola. This was a 4-arm study divided equally amongst arms and stratified by PCR cycle threshold count at baseline, which is a surrogate marker for viral inoculum. A triple monoclonal antibody named ZMAP served as the active comparator, and patients in the remdesivir arm received a 200 milligram load on day 1, followed by 100 milligram daily thereafter for 9 to 13 days. A few key points from the study. Across groups, there was a similar duration of symptoms prior to enrollment, which is approximately 5.5 days. There was a significant correlation between reduced survival and the duration of illness prior to enrollment. Viral loads at baseline were similar amongst treatment arms, and baseline characteristics were generally well matched. There was numerically higher serum creatinine and LFT values in the ZMAP and remdesivir arms, which could potentially signal that these patients were sicker at baseline because they were already demonstrating end organ effects of the disease. In an interim analysis, the decision was made to halt the ZMAP and remdesivir arms due to a clear signal of increased mortality, which you can see in the survival curve on the right. So the results of this trial beg several questions for remdesivir's efficacy. First, was the treatment initiated too late? The latest initiation in the aforementioned animal models was 3 days. Second, was there a flaw in the animal models used for Ebola that explained the seeming discordance between benefit in non-human primates, but not seen in humans? Third, did standard of care or resources impact each arm equally? So the trial was notably impacted by militant groups in the area, which would constantly disrupt medical care due to mistrust of medical facilities and medical providers. So next, let's move on to the clinical data with remdesivir for COVID-19. This report was published recently in the New England Journal of Medicine, which documents some of the experience thus far with the Remdesivir compassionate use program. Initially, 61 patients were identified who received at least one dose of Remdesivir, but 8 patients were excluded from this report, 7 for not having post-baseline data available, and 1 for an erroneous start date which was not further specified. This left 53 patients from several countries in the final sample for analysis. For treatment duration, 40 patients, or about 75% of the sample, received a full 10-day course. 19% received between 5 to 9 days of therapy, and 6% received less than 5 days of therapy. The intended follow-up duration was 28 days, but the patients were followed up for a median of 18 days post-initiation with an interquartile range of 13 to 23 days. Looking at some baseline characteristics for the cohort, the median age was 64 years, and 75% of the patients were male. As a somewhat reliable surrogate for severity of illness, at baseline, 64% of patients required mechanical ventilation, and 8% or 4 patients required ECMO. The median duration of symptoms prior to initiation of Remdesivir was 12 days, with an interquartile range of 9 to 15 days. So overall, these patients were well into their second week of illness prior to initiation of therapy. The manuscript did note that 68% of patients had a coexisting condition at baseline, and the proportion of patients with hypertension, diabetes, hyperlipidemia, and asthma are listed for your reference below the table. So this case series did not have pre-specified endpoints for the efficacy analysis, but they report on clinical improvement as assessed by a modified version of the ordinal scale from the WHO's R&D blueprint. The authors chose to use a 6-point ordinal scale, with the lowest score being 1 for a patient who's been discharged, and a score of 6 for a patient who has died, and scores 2 through 5 being a spectrum of oxygenation requirements, making up the middle of the scale. Now, here is the top-line data that has grabbed a lot of attention. As assessed by this ordinal scale on the left, 36 patients, or 68%, either improved during the follow-up period or were stable enough for discharge. The authors note that 17 of 30 patients who were initially mechanically ventilated were eventually extubated, and 3 of 4 patients receiving ECMO were stable enough to be weaned off during the follow-up period. Additionally, 8 of 53 patients, or 15%, clinically worsened, and 7 of 53, or 13%, died during the follow-up period. In the supplemental appendix, the authors include case narratives for the patients who expired, and the mean age of these 7 patients was 74.5 years, with ranging from 68 to 79 years, which is consistent with previous data. One of the things that has drawn a fair amount of criticism for this article is that although the 28-day follow-up was their target, 28-day data was on definitive outcomes like discharge or death was not detailed for 17 or 32% of the patients, 8 of which were mechanically ventilated at last follow-up, and 1 patient remained on ECMO at the last time point. This makes it much more difficult to reliably interpret outcomes of this cohort. Adverse events experienced by the patients were in line with expectations, with transaminitis occurring in 23% of the patients. Notably, Remdesivir therapy was discontinued prematurely in 4 patients for worsening renal function, multi-organ dysfunction, transaminitis with concomitant rash, and also transaminitis. The authors concluded that there were no new safety signals detected in this cohort. So what can we take away from this report? Well, as many others have already stated, it's very difficult to interpret these data in the absence of a control group. It is unclear if the trajectory of clinical progression was due to the effects of Remdesivir or just the natural course of disease. The authors did mention a few historical cohorts to contrast outcomes, but such comparisons can be flawed due to heterogeneity in patient characteristics, standard of care provided, and also the knowledge available for treating COVID, since our understanding of this disease is rapidly evolving. The study did not have pre-specified endpoints, and the median start day of Remdesivir was day 12 of illness, which is relatively late in the course of illness, potentially impacting efficacy of targeting viral replication. The lack of quantitative PCR precludes the ability to evaluate trends in viral burden. And additionally, this report is at high risk of a few biases, including selection bias, given that patients were screened and granted approval by the manufacturer on a case-by-case basis, sampling bias, as it was unclear if these patients were consecutive compassionate use patients and not all patients were included, as well as reporting bias, given that 8 patients were excluded for erroneous data or a lack of post-baseline data, and there was a high proportion of patients without endpoints. Lastly, the safety profile was consistent with previous data, but it is difficult to differentiate toxicity from underlying disease progression without a control arm as well. So next, let's take a look at the randomized clinical trial conducted at 10 hospitals in Wuhan, China, published in The Lancet on April 29th. This trial included patients with severe COVID-19, defined as pneumonia, hypoxia, or a PF ratio of less than 300. 255 patients were screened, and 18 patients were excluded, 14 of which were deemed ineligible, and 4 who withdrew from the study. This left 236 patients who were enrolled in the final sample, which is considerably lower than the trial's target enrollment of 453 patients because the study was terminated early due to control of the outbreak. Patients were randomized in a 2-to-1 fashion to remdesivir or placebo, with 158 patients in the remdesivir intention to treat population. Of these, 3 patients received no doses of remdesivir, and 5 patients received less than 5 days of therapy. This left 150 patients in the per protocol population, or 95%. So the median age for patients was 65 years, with an interquartile range of 56 to 71. Patients were predominantly male, making up around 60% of the sample, and the majority of oxygen requirements at baseline was comprised of low-flow nasal cannula, making up around 80% of the sample. The median NEWS2 score at baseline was 5 and 4, corresponding to a moderate and low risk severity of illness, respectively. Median duration of symptoms prior to enrollment was 10 days, with an interquartile range of 9 to 12 days, and the majority of patients had coexisting conditions at baseline, with the most common being hypertension, diabetes, and coronary heart disease. So the primary endpoint for this trial was the time to clinical improvement, which was defined as a 2-point reduction in the 6-point ordinal scale listed on the left, which is identical to the one used for the compassionate use case series previously reviewed. For the primary endpoint, there was no significant difference detected for the reduction in time to clinical improvement between remdesivir and placebo. The median times to improvement were 21 and 23 days respectively, with a corresponding Cox proportional hazard ratio of 1.23 and a 95% confidence interval of 0.87 to 1.75. So examining the time to clinical improvement solely in patients that were initiated on therapy within 10 days of the onset of their symptoms, there was a larger numerical reduction in time to clinical improvement with an increased hazard ratio of 1.52. Now, although this is in line with our expectation that benefit is optimized with early initiation, subgroup analyses like these must be interpreted with caution and should be truly only used for hypothesis generation and not for confirmation. No significant difference was seen in the 28-day mortality endpoint. Looking at a few other analyses of interest, on the left we can see the Kaplan-Meier curves for the time to deterioration, defined as a 1-point increase in the ordinal scale or death. We can see that there's no appreciable difference between the patients receiving remdesivir therapy or placebo, and the same similarity between arms was observed in the quantitative viral load curves depicted on the right. No new safety signals were identified in this study, and there was an overall low rate of discontinuation due to adverse events. 12% of patients in the remdesivir arm and 5% in the placebo arm required discontinuation of therapy due to adverse events. There was a notably low rate of transaminitis in this study overall, seeing that only 1% of patients required discontinuation due to ALT elevation in the remdesivir arm. So key take-home points from this study. First, there was actually a control group, which provides us with the highest quality of evidence to date. Overall, though, this was a negative study for remdesivir, as it did not significantly reduce time to clinical improvement, but this should be viewed in the context that the study was ultimately underpowered for the primary endpoint. There was a potential signal that patients initiated on therapy earlier might benefit more, which is biologically plausible, but this must be interpreted with caution. Importantly, there were no significant differences observed between groups in time to deterioration, 28-day mortality, viral load reduction, along with numerous other secondary endpoints. For safety, remdesivir was well tolerated compared to placebo, with an overall low level of discontinuation of therapy. Next, we have data that were very highly anticipated, the preliminary results from the ACT-1 study, which were recently published in the New England Journal of Medicine. For background, these results were generated following the full enrollment of the target sample of 1,063 patients, but not all patients had completed final follow-up by the time of publication. In this first phase, the adaptive trial was structured to compare 10 days of remdesivir to placebo for COVID-19 of varying degrees of severity. 1,107 patients were assessed for eligibility. Of these, 44 were excluded, leaving 1,063 for the final patient randomization pool. Patients were randomized in a 1-to-1 fashion to remdesivir or placebo. Of the 522 patients randomized to placebo, 340 or 65% had completed the study, including death or recovery by the time of publication, and 521 patients were included in analysis. For the remdesivir arm, 541 patients were randomized, 391 or 73% had completed the study, and 538 of these patients were analyzed as well. Patient characteristics were well matched between groups. The median age for patients was around 59 years for both groups. Patients were predominantly male, making up around 2/3 of the sample. Median duration of symptoms for both arms was 9 days, with an interquartile range of 6 to 12 days for the remdesivir arm. For baseline clinical status, the most common baseline category was category 5, or patients requiring low flow oxygen supplementation at baseline. This made up about 40% of patients in both arms. This was followed by category 7, or patients requiring mechanical ventilation or ECMO, which comprised 23% of the patients in remdesivir arm, and slightly more in the placebo arm at 28%. Importantly, analyses were stratified for baseline clinical status to even out these slight differences between arms. The primary outcome was time to clinical recovery, which was defined as category 1 through 3 on the 8-point ordinal scale on the right. These were patients that were discharged with or without limitations on their activity, and patients that remained hospitalized but were no longer requiring ongoing medical care, primarily kept inpatient for infection control purposes. Looking at the results for the primary analysis, remdesivir significantly reduced time to clinical recovery with a median time of 11 days versus 15 days for placebo, and a rate ratio for recovery of 1.32 with a 95% confidence interval of 1.12 to 1.55. Additionally, the analysis adjusted for baseline clinical status demonstrated nearly identical results with a rate ratio of 1.31. Below you can see the Kaplan-Meier curves for this analysis, which shows visible separation between the two arms that appears to begin within the first week of therapy and persists throughout the follow-up interval. The authors conducted several pre-specified subgroup analyses to attempt to further pinpoint which groups benefit from remdesivir therapy. Interestingly, patients presenting with greater than 10 days of antecedent symptoms still appeared to derive benefit from remdesivir therapy with a recovery rate ratio of 1.38, slightly higher than that observed for patients presenting within the first 10 days of symptoms with a rate ratio of 1.28. Now, although the median duration of symptoms was 9 days, from the interquartile range we can infer that 25% of patients in the remdesivir arm presented with 12 days or greater of symptoms prior to initiation of therapy. It is important to note that the confidence interval for these analyses were not adjusted for multiplicity, and as such cannot be used to infer treatment effects definitively. Here we have recovery Kaplan-Meier curves broken down by baseline clinical category. Looking at these figures, we can see the most apparent separation between arms was observed in the patients who required low-flow oxygen supplementation at baseline. A few quick points to highlight here. First, we can see the confidence intervals are much wider in the other groups because these other groups were smaller than the low-flow group, as I mentioned in the baseline characteristics slide. Second, a test of interaction between baseline clinical status and clinical outcome was performed, which did not yield significant results, suggesting that treatment effect was not significantly impacted by baseline clinical status. Third, median time to recovery could not be estimated for patients who were mechanically ventilated or requiring ECMO at baseline in the remdesivir arm due to the protracted nature of the disease in these critically ill patients and potentially too short of a follow-up period. Despite these considerations, it is difficult not to notice that there seems to be no apparent benefit or separation between curves in the patients in the high flow and mechanical ventilation or ECMO groups. This figure is a graphical representation of day 15 clinical status broken down by baseline category. Categories are represented with a color spectrum, with the leftmost categories in shades of red representing worst outcomes, and conversely blue shades on the right representing better outcomes. I think one of the most meaningful information, or one of the most meaningful things that we can take away from this figure is the proportion of patients that worsen from their baseline to day 15 status. So I've highlighted these rates for you. In the ambient group in the top left, the proportion of patients that worsened was 8.3% for the remdesivir arm versus 15.7% for placebo. A larger separation was seen for the low flow group, 8.7% versus 21.8%. This narrowed slightly in the high flow group with 25.4% versus 33.7%, and virtually disappeared in the mechanically ventilated or ECMO patients with 13.9% versus 16.5% of patients worsening from their baseline to day 15 clinical status. Notably, the primary endpoint for this study was initially intended to be clinical improvement on the ordinal scale at day 15. But this was later changed under the advice of trial statisticians, done while they were still blinded to any data for currently enrolled patients. This initial primary endpoint was then changed to a key secondary endpoint, but the results did still show that remdesivir significantly increased the odds of clinical improvement at day 15 with an odds ratio of 1.5 and a confidence interval of 1.18 to 1.91. Looking towards mortality outcomes, in the overall population, there was a non-statistically significant reduction in mortality between remdesivir and placebo, with the Kaplan-Meier estimates for mortality being 7.1% and 11.9% respectively. Now, despite this difference not reaching statistical significance, this is arguably still a clinically meaningful reduction in mortality. Of course, this must be interpreted in the context of incomplete final follow-up for the full sample, which eventually could tip the results towards a statistically significant results or push it further away from one. For safety, remdesivir was well tolerated in the study compared to placebo, with higher rates of adverse events being observed in the placebo arm, which highlights the high morbidity of the underlying disease process. Notably, acute kidney injury occurred at similar rates between arms, and transaminase elevations was observed more frequently in the placebo arm than remdesivir. So what can we take away from this study? First, remdesivir significantly reduced time to recovery, making it the first proven therapy for COVID-19 and also garnering it the standard of care designation in the process. This benefit was similar in the baseline adjusted analysis, and recovery was most apparent in patients beginning in the baseline category 5. Whether this was due to relatively higher enrollment in the baseline category, or simply these patients benefit most from remdesivir therapy is still yet to be determined. As mentioned previously, there was no apparent benefit in patients who required mechanical ventilation or ECMO at baseline. This is complicated by the potentially inadequate follow-up duration for this subset of patients. Also, patients presenting with greater than 10 days from symptom onset appeared to derive benefit, which dispels the notion that a firm 10-day cutoff should be used for treatment allocation decisions. For mortality, there was no statistically significant reduction in mortality observed, but arguably a clinically significant reduction. Lastly, safety data were promising with a lower rate of adverse events observed in the remdesivir arm than the placebo arm, and overall therapy was well tolerated. So this next trial, referred to as the SIMPLE-1 or the SIMPLE-Severe study, was the Gilead-sponsored trial comparing 5 versus 10 days of remdesivir in COVID-19 patients with an oxygen saturation of 94% or lower on ambient air or a supplemental oxygen requirement. Mechanical ventilation, ECMO, and multi-organ dysfunction syndrome were exclusion criteria, but there were a few patients that were enrolled meeting these criteria. 408 patients were screened, 11 were excluded or did not receive treatment, leaving 397 who were randomized and started therapy. This was 200 in the 5-day group and 197 in the 10-day group. I would like to point out that 16 patients, or 8% in the 5-day arm, were discharged prior to completing the full treatment course, whereas 68 or 35% of patients in the 10-day arm were discharged home prior to treatment completion as well. Overall, 86 patients, or 44% in the 10-day arm, completed the full course of treatment, and the median duration of therapy in that group was 9 days of therapy. Patients in both groups were similar in age. There was a slightly higher proportion of male patients in the 10-day group, 60 versus 68%. There was a significant difference in baseline clinical status, with the 10-day group having higher proportion of patients in the high flow and mechanical ventilation or ECMO groups. This difference in baseline clinical status was statistically significant, but was also accounted for in the analysis. The primary outcome for SIMPLE-1 was day 14 clinical status as assessed by the 7-point ordinal scale on the left, which is similar to those used in previous studies, except the severity ranking is flipped, meaning that death is category 1 and higher ordinal categories are actually better outcomes for this scale. The results of the primary outcome analysis did not show a significant difference between 5 and 10-day treatment durations via Wilcoxon rank sum tests stratified by baseline clinical status. For secondary outcomes, there was no significant difference detected in either time to improvement, defined as a 2-point reduction in ordinal scale score, or time to recovery, defined as being a score of 6 or 7 on the scale between the two groups. In a post hoc analysis, the authors examined if there was any benefit of 5 additional days of therapy, or in other words, days 6 through 10 of therapy, for patients grouped by their oxygen support requirements on day 5. This was considered kind of their new baseline. For patients that required invasive mechanical ventilation at day 5, 17% of the 41 patients that received 5 additional days of therapy died by day 14. Whereas 40% of the 25 patients that received no additional therapy died by day 14. Importantly, there was a contradictory trend in outcomes observed for patients requiring high-flow oxygen support at day 5, with 15% death in the day 14 in patients receiving an additional 5 days of therapy versus 10% mortality in those who received no additional therapy. This analysis must be considered with several caveats, including that it was a post hoc analysis, with small subgroups of an already relatively small sample size. Also, there were inconsistent trends across groups, and I would caution readers against relying heavily on these data to inform allocation and treatment decisions. In the supplementary appendix, this figure was included highlighting day 14 clinical status for both treatment arms broken down by baseline clinical status. At the bottom of the figure in blue, we can see improvement rates for each baseline category. And since the study did not have a placebo arm, I've included the improvement rates from the placebo arm in the ACT-1 study to compare. In both the 5 and 10-day groups, day 14 improvement rates for patients requiring invasive mechanical ventilation at baseline were worse than those seen with placebo in ACT-1. But this was a relatively small group of patients. Improvement rates for the other groups in the 5-day arm were similar, if not slightly better than placebo in the ACT-1 study. But improvement was somewhat variable when comparing the 10-day group to the ACT-1 placebo patients. So key take-home points from this study: no significant difference was detected in outcomes between 5 days and 10 days of therapy. Patients who were mechanically ventilated or on ECMO at day 5 that received an additional 5 days of therapy had a lower mortality rate by day 14 than those who did not receive additional therapy. But this was a small post-hoc analysis, and trends for different groups were inconsistent, so this analysis should not be used for treatment decisions alone. Looking at the ever-growing list of available data, we have the addition of top-line results from the Gilead-sponsored SIMPLE-2, or moderate severity trial. The press release included day 11 outcomes data appearing to show a higher recovery rate for 5 days of therapy compared to standard of care alone. But this difference was less apparent between the 10-day group and standard of care. So in summation, considering the data we have thus far, Remdesivir significantly reduces time to clinical recovery, which in essence is the time it takes for patients to be discharged or dischargeable, barring infection control considerations. There was a clinically meaningful but not statistically significant reduction in mortality seen in the overall population in ACT-1. The sum total of the data are not supportive of a hard 10-day cutoff for symptom onset. And additionally, in patients who derive benefit from therapy, it appears that 5 days is equally efficacious as 10 days of therapy, which has significant implications in our current landscape with limited supply available. And lastly, serious and non-serious adverse events have been observed at similar or lower rates than placebo in our controlled trials, confirming that Remdesivir is well tolerated overall. Here are some of the ongoing clinical trials with Remdesivir. The SIMPLE-2 moderate trial will likely be the next to be published, so stay tuned for that. Here are my references and the updated log of changes. And thank you very much for watching, and please don't hesitate to reach out with any questions you might have.